All right, we're good to go.
Okay. Hi, everyone. This is Barb Cochran from the Northwest Geriatric Education Center, and we're here for the Geriatric Health Lecture Series. I am the director of the Dutournier Center for Healthy Aging in the School of Nursing, and today I'm representing the Northwest GEC. And I do want to mention again that these lectures are sort of within the week getting posted up to our nwgec.org website. So if you know of somebody that really wanted to hear it and missed it, they can access it that way. They just need to register on the website. And you should have from your site coordinators, if you're wanting to get continuing education contact hours, an information sheet that tells you where to go online to register with CNE. I'm just going to mention it here because it gets detailed, but it's www.uwcne.org/node, N-O-D-E, /336. And you can register and then confirm attendance each time you sit in on a lecture or just at the very end, whichever is your preference. And so this year you'll be able to pay for your contact hours online rather than having to write a check. So today I'm very happy to introduce Susan McCurry. I know that you were expecting to hear David LaFazia today, and he's been called away on a family emergency. So I told Susan she's my hero today, stepping in for David. And Sue works with David. She's a research professor of psychosocial and community health in the School of Nursing. She has 23 years experience developing and conducting randomized controlled trials of non-pharmacological interventions for older adults with cognitive impairment, including sleep disturbances. And she has authored over 100 peer-reviewed articles, 2 books, and training video for family caregivers and healthcare professionals on the management of mood and behavior changes in dementia. And she, along with Rebecca Logston, are principal investigators with Linda Terry's research group in
Northwest Research Group in Aging.
Thank you. Northwest Research Group in Aging. They have an entire career of incredibly important studies on caregivers and individuals with cognitive impairment, along with a lot of other things. And so they're all working together, and David LaFazia is also a part of that group. So I think these slides might have been ones that you developed in the early days, right?
Some of them I've seen before. Yeah.
So she does know the content intimately, and I'm going to let you talk about supporting caregivers and coping with challenging behaviors.
Okay, great. Thanks. Well, thank you very much. I'm happy to be here to speak with you all, and I know David's very sorry he can't join us today. So the arrow key doesn't seem to be working to move it forward. Is there a problema?
Hello. I've arrived.
Ah, now we just suddenly got it to. Oh, so I can't use these arrow keys?
Oh, no, sometimes they get a little locked up. So,
okay.
but you can use them now. So.
Oh, okay.
Yep.
Sorry about that. So there's a quote from Rosalyn Carter that I really loved. It says, there's only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. And I think that really speaks to what we're talking about today. David included this slide talking about some of the statistics about caregiving. The need for caregivers in this day and time is just enormous. And it's only going to be increasing exponentially as we have the aging baby boomers that are coming into where they're going to start needing care. And most of the caregiving that's done is by family members. In our country, in our culture, we prefer to keep people at home and independent as long as possible. And so we have folks, as they grow older and more physically frail or more cognitively frail, they're cared for by their spouses, by adult children, and I'm seeing in my own practice more and more neighbors that are stepping up to the plate, church, community members that are trying it. So it is becoming, it takes a village to care for our elders, as I think it should be. But there are a lot of people needing care and a lot of people providing care out there. And not surprisingly, as a person's level of cognitive function declines over time, as they go from being a normal, healthy, maybe somewhat physically frail elder to having moderate to severe dementia, the amount of time that's spent delivering care really jumps up for family caregivers. This is all primarily unpaid care prior to when someone is unable to stay in their own home. So it's quite a bit of time, and if you've got an adult child, this child may also be raising teenagers and working a job and trying to juggle many balls at the same time they're providing this care. So if we think about what are the main issues in providing care to someone who's cognitively impaired, memory problems are not really what caregivers are focused on. They are problematic, of course, in the sense that a person may not, remember how to dress or how to bathe or, remember what, but it is not the fact that a person can't remember what they had for breakfast that's disturbing to a family caregiver. It's these other kinds of mood and behavioral challenges that emerge. And these happen in almost everybody who develops a dementing illness at some point during the course of the disease. They tend to get worse as the disease progresses, maybe fall off some towards the very end, but kind of the moderate stages are often the most difficult. That's the primary reason someone is no longer able to stay at home, wind up being institutionalized, and they can be difficult and thorny to treat. And so I think that's what we're going to be talking about today, is some of what are the causes of these kinds of mood and behavior disturbances, and what are some of the strategies that we can use to manage them. This slide just illustrates that some of the symptoms that we see, symptoms of anxiety and depression particularly, are very common in this sample of 500 individuals, 500 plus individuals. Almost half of them are exhibiting symptoms of anxiety, which includes getting agitated and depressed, kind of suspicious and irritable, or symptoms of depression, withdrawing, not wanting to do activities that they used to do, tearfulness. Some of these other behaviors, sleep problems or wandering, those are a much lower frequency of occurrence, but of course they're very problematic when they do occur and can be a great source of stress to the family members. So what causes behavior problems in dementia? And I think we can put this in kind of a four square. There are four main areas that contribute to these problems: physical causes, prior experiences and personal history, cognitive changes, and environmental factors. And so let's look at each of these separately. So physical causes, brain chemistry changes and damage to specific areas of the brain. This is going to depend upon the kind of dementia that a person has. So someone with Alzheimer's disease, for example, is going to probably show clear symptoms of memory loss that get worse over time, as well as some of these other problems. A person with Parkinson's disease dementia or Lewy body dementia may have more hallucinations. Someone who's had strokes may be prone towards episodes of uncontrolled crying over seemingly nothing. A person with frontal lobe dementia may exhibit some pretty unusual changes in personality or judgment. And so the kinds of symptoms a person with dementia has first are directly caused by the type of dementia they have and the part of the brain that is affected by that dementing illness. Then, in addition to that, behavior changes are to some extent caused by age-related physical changes. I mean, if I get up in the morning and I have a cold, like I do, I don't function as well as I do when I'm perfectly well. If I have a headache, if I'm feeling nauseated. Well, that's true for older adults with dementia as well. And because of their age, they're at greater risk to have all kinds of medical conditions. They may have osteoarthritis with considerable pain or mobility limitations. They may have emphysema, difficulty breathing. They may have problems that require them to use diuretics, so they're having to get up during the night and, with incontinence episodes. So you've got these physical changes that also affect how a person's feeling, and that affects how well a person can function. And you put a dementia on top of that, and those can really exacerbate one another. And then there's a delirium. In some cases, a person has an acute medical condition that may be related to medication side effects or to an untreated, maybe undiagnosed infection. And a delirium tends to come on quite quickly, But it is often undiagnosed or underdiagnosed in people with dementia because delirium symptoms are attributed to a natural progression of the disease. So I've seen cases where people who have been very mild-mannered with their dementia become quite agitated and combative, and the family is told by the family doc, well, that's just because it's Alzheimer's disease. That's what always happens to people with Alzheimer's disease, and that's not true. And it's a sad thing because, of course, a delirium can be a life-threatening emergency if it's not properly treated and managed. And if it is treated, then these symptoms can clear up and a person can return to a baseline level of functioning. So in the early stages of dementia, when we're thinking about physical possible contributions, you really want to think about, for one thing, sensory deficits. You know, if a person can't hear what's being said, then they're more likely to be suspicious and think that people are talking about them, which, of course, often is the case in persons who live at home with family members. If they can't see, they may be more likely to have visual misperceptions. You want to definitely, if there's a sudden change in mood or behavior, check into the possibility that there's something going on with medication, some sort of acute illness, or is there something medically that's going on that is causing the person discomfort or difficulty getting around in their day that might be particularly frustrating given their dementia. As dementia progresses, things that are physical we need to think about that can be overlooked, hunger or thirst. People with dementia often aren't able to express their needs in a way we think, oh, well, you should be able to say, well, I hurt here, or I want a glass of water. But if you think about it, when we raise small children, it takes us quite a few years to train them to accurately report to us what their inner experiences are in a way that we can give them what they need. And people with dementia start to lose that ability to express their needs and to describe their inner sensations properly. So we want to rule out possible pain. There are studies that show the number one cause of agitated behavior in nursing home settings is undiagnosed and untreated pain. A person may need to use the restroom, or they may just be tired. You know, it takes a lot to go through a day when you're not working on a full brain reserve, and they may just need some rest, uncomfortable clothing or shoes. So we definitely want to look at physical causes, and these are important because many physical causes of behavior changes in people with dementia are treatable. They are rectifiable, and we want to fix them if we can. Okay, prior experience and history. I think this tends to sometimes get underappreciated in folks with dementia. People with dementia are just like you and I. We maybe don't have dementia yet, but we have personalities, and we interact with people, and we relate to the world based upon our histories and our experiences and what we've learned along the way. And that doesn't just go away because a person develops Alzheimer's disease. So we want to understand their history and its impact on current behavior, both their strengths and things that are weaknesses. For example, a person who has been exposed to a trauma in their younger life, a woman who has experienced assault, may be quite frightened when her husband, who she doesn't recognize, tries to change her. Or a veteran who has served in combat may become quite agitated when another veteran barrels into his room in the nursing home and he doesn't recognize him and thinks perhaps he's in danger and he may strike out. Similarly, people have strengths. Someone who has been an artist in his or her younger life may find great satisfaction and joy from continuing to paint or draw. Even it's not exactly like it was when they were younger, but it still may bring them great gratification because this has been something that brought them joy. Knowing a person's history can help create a comfortable environment. I've worked with people who survived the Holocaust and found great relief in being in a place like Klein-Gallen Nursing Home here in Seattle that serves the Jewish community because, you know, the beautiful Judaic art and the seasons, the holidays, religious holidays, and there's just a rhythm and a pacing, and of course a great compassion and understanding among the staff of what someone like that went through that can help create an environment that they can thrive in. So again, we want to really think about prior experience and history, what kind of occupation a person had. I worked with someone once in a nursing home who was quite agitated, and He had been a physician in his prior life, and he was about to be discharged because he was so agitated in the facility. And the head nurse started taking him on morning and afternoon rounds with her, and she'd hand him the clipboard and the pencil, and he'd walk around from room to room and round with her, and then they'd go to the nursing station. And when she started rounding with him twice a day, his agitated behaviors completely went away, and he became one of the most beloved individuals on the unit. And it was because she tapped into his history, what gave him a sense of worth and of value, and also kind of patterns and rhythms that he had lived for many years. So we want to definitely think about, I've got a friend now who's got quite severe dementia. He was a wonderful dad growing up, and nothing is better for him than to go to his son's house and plop on the couch with 3 giant dogs on top of him and watch football all day. And then he's like just completely, he's not tracking with the game, but it is consistent with his history and what he's always loved. Cognitive changes, okay, this may seem obvious. A person with dementia has cognitive changes, but there's lots of ways that the changes that happen in the brains because of dementia affect mood and behavior. So some of them are memory problems. So a person may not remember recent events, or they may not remember past events, or they may just not be able to pay attention. So they can remember if you can get them to attend, but they can't hold on to that attention. Interestingly enough, I should say as an aside, for those of you who don't know, the new DSM-5 diagnostic manual does not require memory loss as a component to get a diagnosis of major neuropsychiatric neurocognitive impairment. That it has to, the cognitive changes can have to be a change from the past, and they have to be interfering with function to be called a major neuropsychiatric disorder, which is the equivalent of dementia, but it doesn't require memory problems. So just sort of an interesting factoid. You can still remember pretty well and be quite severely impaired cognitively. There's confusion and disorientation. You know, a person who, it's not just they may not remember the date or where they are, but they may have perceptual problems, so they don't recognize their home. And so it's a kind of confusion that might be frightening to them and lead to agitation and wanting to leave because they aren't perceiving properly. Communication changes. People with dementia lose both the ability to understand what we're saying to them and to communicate clearly their own needs. And both of those can cause a lot of frustration. If a person with dementia is trying to express themselves and the caregiver either isn't getting it properly or is trying to speed them up because it's not coming out fast enough, that can be quite frustrating. And similarly, the caregiver may think he or she is communicating clearly to the person with dementia what is needed, and the person with dementia may be nodding and as if I got it, and then 5 minutes later either they've just forgotten or they never really understood what was being said in the first place. So this can be quite a source of conflict between caregivers and people with dementia, these communication deficits. And impaired judgment, you know, we think of impaired judgment as being sort of classic stories where someone starts giving all their money away to a questionable charity, or a very staid widower runs off with a pole dancer or something. But I think sometimes impaired judgment is just the person with dementia is not behaving as we are accustomed to them behaving in the past. And so that's very frustrating. It seems like they're not behaving properly because they're acting differently than they've been in that context. And certainly people with dementia lose their ability to modulate their behaviors. They may overreact in situations or underreact in situations. They may start engaging in a behavior and be unable to stop on their own, or they may have difficulty initiating behavior. So all these are tied with changes in, you know, executive function and frontal lobe functioning. And each of these can lead to their own kind of mood frustration, depression, poor self-esteem, or behavioral agitation, suspiciousness, conflict with family members. So it's important, again, to think about what kind of symptoms does a person you're working with have, and how might their particular symptoms influence the way they're feeling and acting. In the early stages, what we mostly see is these changes in memory and kind of Often there's lack of insight. People don't realize that they're having trouble, and so they're particularly frustrated when the family members are trying to step in and try to provide more help than they think they need. This is a very difficult stage for many family members because the person with dementia may look exactly the same. They don't look sick, they don't act sick, they just are being unreasonable or are doing things that in the beginning they're small enough you think, oh, well, maybe this is nothing, and then as they begin to accumulate, you become aware that it's a more serious problem. Later on, this inability to follow instructions or understand situations becomes much more problematic, in terms of your ability to leave someone alone, leave someone in the care of someone else, to provide assistance with activities of daily living that the person may or may not want assistance with, and you try to discuss it with them and reason with them why they need this help and talk them through the steps, and maybe they're not processing what you're saying. So in later stages, these cognitive deficits really start interfering with just ability to get through your day and the most basic activities of dressing and eating and bathing. Environmental causes of mood and behavior changes in dementia, some of those there may be physical cues in the environment that trigger behaviors, objects that are confusing, or people, both peers and caregivers. So, for example, too much activity. There's a lot of commotion in the house. Sometimes people who come from a large family who have always done great in these, giant family gatherings may start having a lot more difficulty and withdraw when there's that many people around. They start to do better in smaller settings where there are few people, less stimulation. Clutter, being rushed, changes in routine. And I think some of these early stages that cause trouble for folks is they just are not able to process information as quickly as they used to be able to. So when a lot is coming at them, they just can't take it in and figure out how to respond. They can't track multiple conversations. They can't think as quickly. And so the more overexposure, overstimulated they are, the more likely there is to be difficulty. As the dementia starts to progress, you may have other things in the environment, such as inadequate lighting. That's considered one of the major triggers for agitated behaviors in sundowning folks. As the light starts to go down and maybe can't see so clearly outside, and there's glare on the windows and the mirrors and confusing cues, it might lead a person to become frightened or agitated. Personal care is a primary trigger for agitated behaviors in folks with dementia. Again, often because they don't appreciate that they need help with these things. As far as they remember, they have bathed already. These are fresh clothes. I've been getting myself dressed every day for the past 82 years. I don't need you to help me do it. And so kind of environmental triggers also can impact a lot of these behaviors. Other agitated people, this is particularly a problem in long-term care facilities where you may have many people that are, on a unit that are calling out or wandering into one another's rooms or becoming excited, and that can really set off an escalating pattern. So again, if we think when you've got a behavior change in a person with dementia, you want to think about each of these as you're trying to figure out what to do. Are there possible physical causes for what you're seeing? Are there cognitive changes related to the brain disease? Are there things in their personal history that make them likely to become upset or depressed or anxious in this situation? And are there environmental factors that may be contributing? And it seems simple, but in practice, when something happens that catches you by surprise or when there's a recurrent difficulty, it is surprisingly tricky to forget to think about each of these components. So I'd encourage you just kind of think of this foursquare as you're looking at behaviors that happen in people that you care for. So when should we intervene? Choosing our battles. You certainly, if you've got a situation where it's very distressing or frightening to the person, it's creating an unsafe situation for the person with dementia or those around him, or it's causing significant distress to the caregiver, preventing necessary care. These are important. So, for example, the caregiver says he doesn't eat neatly with his fork and spoon anymore. He spills his soup when he eats. Well, that maybe isn't an important enough thing that you want to be focusing on it. Except if it's causing great distress to the caregiver, because this has been a household where the queen comes and visits like every year, and it's important that everybody be neat at the table, then that's fine. It's fine game. And I guess my point is that sometimes knowing how to choose your battles can be unclear. Something may be creating an unsafe situation for an individual, but there may be a benefit to it for the caregiver. So, for example, maybe a better example would be, say the person with dementia wants to sleep all day because he's tired. So staying awake, being forced to stay awake and engage in activities is distressing and upsetting to him. But for the caregiver, having him up during the day means he's less likely to be up during the night. And so you can have, it's not always a simple thing to decide what you should be working on and what's the best strategy to approach it. But in the end, whatever happens with people with dementia, caregivers are going to be the ticket. You know, a person with cognitive impairment is increasingly unable to modulate their own behaviors. They may not have insight into what they're experiencing or what they're doing. They may not have a good perspective on how what they're doing is impacting the world around them. They may not remember things that have happened correctly or at all. And so any kind of problem-solving intervention that we're going to do with folks with dementia increasingly must rely upon the caregiver's intervention and input. I know last week you were hearing about folks with mild cognitive impairment, and of course we're on a continuum here, and when things are very mild, people are often quite capable and articulate. They've been doing this special on NPR with a person with early Alzheimer's, and you know, who's written a book, and he's got a blog, and he's, you know, quite articulate in describing his experiences of what he's going through. And yet even he is talking about how he's having to give things up and how difficult it is to accept that. And so caregivers really have to start taking over. We want to really focus on the caregiver-care receiver dyad. I think it's so important to remember, if it's good for the person with dementia, it's good for the caregiver. If a person with dementia is happy, feels good about themselves, is comfortable, is not upset and distressed, then the persons caring for them are going to also have a better experience, and they're going to be able to enjoy each other more. So there's been a number of randomized trials that our research group has done that have shown that non-pharmacological interventions can make a huge difference in alleviating some of these mood and behavior problems of dementia, and that they improve the quality of life and the mood for both the persons with dementia and the caregiver. So why do we focus on behavior? Well, we focus on behavior because at least at this point, we can't do anything about the changes in the brain that are causing, the cognitive changes. We can't stop or reverse or prevent the progression of dementia at this point in time. But we can, even with a person with cognitive impairment, can change how they're responding to their situation by helping change the situation, the context that they're in. And in doing that, we can improve their functional status and improve quality of life. So the work that I'm going to be presenting here for David is grounded in a series of interventions that our research group has done called the Seattle Protocols. And they're derived conceptually from social learning theory, which talks about how specific behavior problems, particularly depression, it was focused on depression in the early days with older adults, how these problems develop and maintained, and then gerontological theory that talks about the context of these problems for older adults, what's special about aging, and the way that people respond to their environment, and the environment responds to them as older adults. And we've been doing randomized clinical trials for over 25 years now. And this slide just shows, it summarizes some of the studies that we've done. We've looked at using non-drug, non-pharmacological interventions to treat depression, agitation, physical inactivity, sleep problems. We worked with early stage memory loss individuals. So we've applied these basic strategies to a whole host of problems, people in assisted living and adult family homes, as well as in family communities. So in a lot of environmental settings, we've done training with AAA case managers and nurses' aides in nursing homes and assisted living facilities, as well as family members. So we've got a lot of experience kind of teaching these approaches to people. Just to briefly summarize, what we've found is that these approaches work, that we can reduce depression in people with dementia and caregivers, that we can reduce their risk for being institutionalized because of behavioral problems. We can reduce caregiver burden, reduce how distressed caregivers are by behavior problems that are occurring, reduce family conflict, improve sleep. So we've had great success with these strategies. And the protocols are built upon this idea that we as clinicians are working in a partnership with the caregiver. The caregiver is the expert on the person with dementia, and the person with dementia, him or herself, to the extent that they're able to articulate their preferences and their wants and their needs. You know, we are not the experts. We come in with a set of skills that we want to teach people and share with them, but we want to work together. These protocols are standardized. They follow a series of steps that we're going to talk about, each of the pieces in the protocols, the core components, but they're individualized to each situation because every household is different. Every person with dementia is different. If you've seen one person with Alzheimer's, you've seen one person with Alzheimer's. You know, each person has different problems and issues that need to be grappled with, and so we want to have general principles that we teach caregivers that can be applied to very specific situations. They are a set of skills people can build, and then hopefully once we're not in there visiting with them anymore, they are sustainable. They're skills that can be applied at any stage in the disease process with any kind of problem that arises. So once a caregiver gets the concepts, the principles, they're quite generalizable and flexible in how they can be applied. So the first core concept of the Seattle protocols has to do with what we call realistic expectations. And that's just an understanding and appreciation of how dementia affects a person, how it changes a person's ability to function and do the things that they did previously. You know, dementia is a brain disease. I sometimes put up a slide that I've gotten from a neurologist here at the UW that shows a healthy brain at autopsy and an Alzheimer's brain at autopsy. And the Alzheimer's brain is full of holes. And it really dramatically shows that the neurons are not able to connect the way they used to because they simply are not there. The brain is disappearing, big chunks of it. And so everything that a person does, the way they think, they feel, make decisions, and react, is being influenced by this disease process. And people with dementia do not have volitional control over their actions. In the beginning, they have more control than they have later on, of course. But it's a slippery slope and a continuum, and we don't have an X-ray that can say, we can take a snapshot of someone's brain and say, oh yeah, he's being difficult because he's always been difficult with mom when he didn't want to be told what to do. Or he's being difficult because he has moderate Alzheimer's disease and he doesn't have control over this behavior anymore. And so caregivers need to just begin to grapple with the fact that increasingly it becomes true that a person with dementia does not have control over these symptoms. They're not just doing it to irritate us. This is part of their disease. And that part of the disease is these symptoms fluctuate, sometimes unpredictably. You know, I like to think of it as it's being a light switch. It's sometimes on and sometimes it's off, but sometimes it's just flickering. You know how the bulb sometimes when it's going out is flickering. That a person can be quite impaired when they're at home, just being in their daily life with their spouse. And yet when Aunt Mildred comes and visits from New York for the weekend, they pull themselves together and they go and tour Seattle and they look at pictures and they tell family stories and they seem great. And Mildred goes back home and she says, gosh, there's nothing wrong with Joe. His wife's just exaggerating how bad he is. But as soon as Mildred's gone, Joe falls apart again. Or we see this with doctor's office. A person really pulls themselves together when they and the spouse walk into the doctor's office. The doctor says, I don't think there's anything wrong. He's just had a lot of birthdays. So, he's fine. So these symptoms do fluctuate, and that is normal. That's part and parcel of these diseases. And because of their brain disease, people with dementia may not realize how much help they need. So in the early stages, in the very early stages, of course, if a person's starting to have cognitive symptoms or behavioral symptoms, you need to get a medical evaluation to rule out treatable causes of these symptoms. There are many things that are treatable and reversible that can cause, I get people calling me on the phone and say, Mom was fine 2 weeks ago and now she has Alzheimer's disease. Well, that's not Alzheimer's disease. There's something else going on, medical and reversible and potentially seriously threatening to them if it's not treated. But we want people to be independent, keep their normal routines as much as possible. I encourage people in the early stages to really set up very consistent walking and sleep routines, just as a matter of course, just to get that kind of regularity in their daily schedule. You should expect that there's going to be gaps in ability. It's going to be inconsistent, and again, that changes are not due to lack of motivation or denial. Later on, realistic expectations is going to involve caregivers monitoring things like driving and medications and personal hygiene. And this can be tricky because, again, of that inconsistency of someone may be able to take the bus downtown one day and may get lost next week when they do it. Does that mean they can never take the bus again? It can be difficult to know. When do you start taking, the checkbook away? When do you make the person stop driving? How do you do that? Safety concerns are very important. I often in my talks ask audiences, what's the biggest thing that, people are reluctant to give up when they get demented? And everyone always says driving. But in my experience, the thing that people are most reluctant to give up when they get demented are their guns. And I've seen terrible things happen with people with dementia and guns because they don't have good control. They don't have good gun behaviors anymore, but they still have very dangerous weapons in their homes and can be quite, threatening to the people around them. Caregivers realistically should not expect that the person is always going to accept your help. Sometimes caregivers bring someone to me and they say, well, if you would just, say it you have the magic words you'll say and they'll understand, oh, that's right, I can't live at home independently anymore. I have to go to assisted living, People with dementia are often been very independent, powerful, in control people, and getting dementia doesn't necessarily take that drive away. So they may not accept your help, and you have to expect that. You have to expect that sometimes you're going to be disappointed or embarrassed or resentful that they're not grateful or just exhausted. And again, that's part of the realistic expectations for the caregiver as well as what to expect from the person. So the second component of this foursome in our Seattle protocols focuses on effective communication. We talked about how communication is so important, and isn't that the truth? I mean, all of us, whether it's with our spouses or our friends or our children, communication can make or break any relationship. And as I said earlier, dementia affects both expressive language, the ability to say what you want to say articulately in the way you want to say it, and receptive language, the ability to understand what's being said to you and to process that information quickly and correctly. And as dementia progresses, communication becomes less verbal and more nonverbal, more body language. So, for example, a caregiver said to me once, she said, last night I had minestrone soup for dinner, and I had just mopped my white kitchen floor that afternoon. And my husband knocked the bowl of minestrone soup, and it went all over this clean white kitchen floor. And she said, I was mopping it up, and I said to him, that's all right, hon, don't worry about it. She said, but I only realized as he got really upset that what I was doing is I had this big cloth and I was wiping it up as fast as I could, and the tone of voice I said, "That's all right, hon," was a pretty mad tone of voice and a pretty impatient one, and kind of I was rolling my eyes, and he got upset. He didn't know what was going on, but he knew she was upset. So in that situation, I think it's pretty clear. What's the message he got? Did he hear, "That's all right, hon, don't worry about it"? Or did he hear in quotes, something bad has happened and you're mad at me and now I'm on the defensive? So that's something to be aware of. Caregivers have to learn to be nice, to be polite pretty much all the time. Because if you can't do that, then you're going to be creating a situation where you may inadvertently trigger an agitated or an upset reaction. This is a story. This was actually, sadly, it was a psychologist who said this very quote to me once. She's taking care of her mom, and I was sort of stunned at this quote. You know, her mother was having, she was misreporting an event, who had done her hair. And the daughter's take on it is, you know, do you have any thoughts on these kinds of episodes where a person denies an obvious reality? And just sort of the tone of that question, isn't it like, oh, well, just snap out of it? You know, it's obvious it wasn't your sister who did your hair. She lives back in New York City. So again, with an attempt to orient the person with dementia to reality, the caregiver is inadvertently actually making the situation worse rather than better. And I think after years of doing reality orientation in nursing homes, many of us have gotten away from that because we had that experience. We learned that correcting a person over and over again and telling them no, they're not right, that what they think is wrong, often doesn't build relationships and sustain, you know, a quality of life for the person with dementia. Just aggravates them. So in the early stages with communication, I think trying to not be in a hurry is so important. You know, in this respect, sometimes caring for someone with cognitive impairment is like caring for little ones. The more you're in a rush to get out the door, the more sort of things just kind of go south. I think it's best if you can take time, and if you're not going to be able to get out when the timing you want, then maybe you need to go out tomorrow instead of today. You want to make sure the person understands instructions. In early stages, written instructions can be extremely helpful. Labels can be good at helping orient people to where things are in the kitchen, or leaving notes. I'm going to be back at 3 o'clock, you know, sitting next to a clock. This can be helpful. But you definitely want to avoid challenging the person. You know, watch your tone of voice. As much as it may seem like, you know, water torture, I encourage people to answer repeated questions as many times as they're asked. You know, for the person asking the question, it's a brand new day. They wouldn't ask you again if they remembered they asked you before and you answered. So it's like a fresh question for them, and so to try to be patient with that. In the later stages, I really do think kind of a pleasant, non-threatening body language, a pleasant tone of voice. It should not be patronizing. We want our elders to be treated with great respect, and that's true of people with dementia as well as any other elder. So we don't talk to them like they're children or like they're not there when the daughter comes to visit. But we do want to be pleasant, have good eye contact. You need to speak clearly. You don't have to shout. I've had people in clinics say to me, I'm not deaf. Try to reduce distracting background noises. Do one task at a time. Our colleague Linda Terry has this little phrase she uses as kind of a jingle. Listen with respect, comfort, redirect. So it's kind of easy to remember. And it sort of captures this good communication thing. The idea is you want to listen, make eye contact. I mean, don't stare a person down if they're uncomfortable with being looked at. You don't have to kind of like, give them the eagle eye, but you want to pay them attention so that when you're talking to them, they know you're talking to them, and when they're talking to you, you have the appearance that you're listening. You want to listen to the nonverbal communication as well as the verbal. If a person is upset and they say, "I hate you," does that mean they really are saying, "I hate you"? Or does that mean they're saying, I don't understand why you won't give me the car keys when I want to go down to the store by myself, you know, and I'm frustrated. And so we want to kind of listen to, respectfully, to what's being said underneath the words as well as the actual words. And then try to provide some sort of reassurance to the person. It doesn't have to be modeling, but some sort of acknowledgement that you understand. You know, I can hear this is really frustrating to you that, you know, the DMV took your driver's license away. Or, you know, it sounds like you're really worried that your daughter's not going to come visit today. And, you know, that's okay. I'm here right now. And, you know, I'm not going to leave you. And then try to redirect. Try to help change the subject, redirect to a different activity, a pleasant activity if possible. You don't want to redirect too soon. Some people just sort of jump as soon as the problem happens. They leap into redirection without these other steps. And often that will go awry because you haven't acknowledged the person. You haven't given them a message that I hear you and I respect you and I understand you and I'm here with you before then you try to redirect them to something else. So don't rush to redirection too quickly. This is just a very nice quote. It's if you haven't ever looked at the parentswish.com site, I don't even know if it's still up to tell you the truth, but I love this whole idea, you know, just reminder if we, you know, are saying the same things over and over again, well, so did you when you were little, and we loved you through that, and so please be patient with us and do the same thing. Okay, treating behavioral disturbances. The third arm of this four-legged stool is ABC problem-solving approach. So what the ABCs are, it talks about problem behaviors occur on 3 parts. If we start in the B, someone has said to me, it shouldn't be ABCs, it should be BAC, because you start with the B. You have a behavior that is something you're disturbed about, and a behavior can be anything. It's something that you can see, it's observable, and it's a problem for some reason. So it might be the person is crying. The person is saying they want to go home, even though they are home. The person is wandering in the middle of the night, trying to go to work when you know, they're retired and it's 2 a.m. So there's a behavior that's happening that's a problem. And what we want to look at is what happened before. The old behavior analysis term for that was antecedent. And these slides are kind of a mix. Sometimes they use the word antecedent, sometimes they use the word activator. Activator is kind of a little more energizing, but antecedent captures is what happens before the behavior. So before the person starts saying, I want to go home, something was going on. It's a certain time of day, there's certain people around, they're in a certain physical environment, they've been engaged in some sort of activity. There's something happening before the problem behavior emerges. And then once it emerges, there's a response, a consequence. The caregiver or someone else in the environment responds in some way. So the caregiver might try to redirect someone, or they may say, you already are home. Or they may take him in the car and drive him around and then bring him right back and say, oh, here we are home. They have any number of responses that they may do to the problem behavior. And the response will either increase the likelihood of the behavior getting better, it'll make the situation better, or it'll make the situation worse. So we want to look at sort of this big picture, and it's presented as a linear sequence, and in fact it's a lot more complicated from that. There's activators and consequences going on all over the place around any kind of a problem behavior. But for simplicity's sake, let's just sort of think about it in these 3 terms. So we have a problem behavior. What we want to do is we want to identify, is there an activator that triggered the behavior, or more correctly, are there certain situations in which this behavior is more likely to occur? And if you can identify there's certain situations when the behavior is more likely to occur, then you can change that. So if dad always puts up a fight if mom tries to give him a shower, but dad happily will shower with the nurse's aide that comes twice a week, well, there's an example of 2 different situations. In one situation, agitation around showering is activated, and in the other situation it's not. Those 2 situations are different, and you can look at what's different about them and see if you can increase the likelihood that the non-activating situation will be present. If you do that, you might eliminate the problem behavior happening altogether. Occasionally, if you find the right trigger, the right activator, the right situation and change it, you can make a miracle happen. a month from now, there'll be a new problem, so it's not like all your troubles are solved. But occasionally, the right activator can be very powerful. And of course, if you can prevent a behavior from happening in the first place, that's great. But can't always do that. So sometimes what you have to do is you have to look at the consequence, what can be changed in the consequence. So if when, Dad says, I'm not going to shower, Mom starts to yell at him and complains that, you stink and you haven't showered for a week and a half and I've had enough with this, and, tries to drag him into the bathroom, well, chances are that's going to escalate the situation. It's going to make it worse, not better. Whereas if Mom could find a different way to communicate, a nicer tone of voice, if she can brainstorm other ways, like maybe offering a shower in the morning works better than offering at night, or if perhaps a bath works better than a shower, or perhaps saying, okay, that's fine, and walking away, and 5 minutes later coming back with nice warm towels that have been heated up in the dryer, saying, oh gosh, they're ready for you in the shower. Any number of different responses might work better than yelling and criticizing. And so what we want to do is look at the consequence, and did that make the situation better or worse? And then brainstorm things that you could change, just like we brainstormed things in the activating situation we could change to try to modulate the situation. So overall, the ABCs, what they do, they can prevent the behavior from happening altogether in those rare cases when you find the magic activator, or they can keep a current behavior from getting worse or continuing. If you change your consequence, you may not keep it from escalating, or may even stop it from happening. Or you can reduce the probability of it happening in the future by changing either the activators or the consequences. You can reduce the reinforcing power of it. I mean, if Dad, he refuses to shower, Mom gets really upset, he gets upset back, and she never asks him to shower again for another 2 days. In a sense, he has his agitated response has been reinforced, right? He's learned that if he yells at his wife, she won't make him do something he doesn't want to do. So all of these things kind of have to be thought through to come up with an effective plan. So the ABCs overall, first you define the behavior, or the BACs. What is the current behavior? Who's it happen around? Where does it happen most? When does it happen? We call this the 4 Ws. And this is trickier than you think. I mean, I bet everyone listening to this talk who's worked with someone with dementia can think of a problem situation, and if you were to start to tell it to me right now, it'd be about 8 sentences long. It'd be a story. And in that story, there'd probably be 6 or 7 points at which one can intervene. And so it can be tricky sometimes to figure out what exactly is the problem and where do you want to intervene. And the good news is it doesn't matter. Behaviors that are part of a complex sequence, you can intervene at any point along the way and often make a big impact on a lot of the whole chain. But you just have to pick one point, because otherwise you're not going to be able to use this model. You have to pick a place to start so that you can look at what happened before and afterwards. So again, these are just the 4 Ws. What's the person doing? Who's around? Where's it happening? When? So these are some good examples of not good target behaviors. So if I say to someone, let's pick a behavior, what behavior do you want to work on so we can practice this? It's not helpful to me if they say she doesn't try to do something, or he's disorganized, or she's in denial, or he's depressed or anxious or agitated. And what's not good about these behaviors is they're either too vague, like he's depressed doesn't tell me what he's doing. Is he crying? Is he threatening to harm himself? Is he saying life isn't worth living? Is he refusing to go out and engage in activities he used to enjoy? Does he have a sad face? What exactly is he doing? It's too vague. In other cases, it's kind of a critical interpretation, like she doesn't try, or he's in denial. Those are kind of mean-spirited interpretations we're putting on the behavior, which are not going to be very helpful, because we don't know if they're true or not. Maybe she's in denial and maybe she doesn't try, but it doesn't matter. From our point of view, for this exercise, those are not helpful perspectives. So instead of these kinds of target behaviors, what we want are things that are specific and observable and that clearly interfere with care or impact quality of life. So specifically, he won't get dressed, or she won't take her meds, or he eats too many sweets, he refuses to shower. These are very specific behaviors, and so if it's he refuses to take a shower, we can start to look at, okay, if you're refusing to take a shower, when was the last time he refused to take a shower? Oh, last night. Okay, let's talk about last night. What was happening before what exactly did he say when he refused, and how did you respond, and what was happening before? So we can work the ABCs when you have a very specific behavior like this. So again, think that when you are coming up with the 4 W's, picking a behavior to work on, you want to try to be specific, observable, countable, and to appreciate the fact that multiple behaviors are complex. There's lots of causes and effects, and if you try to fix everything at once, it'll be overwhelming. So again, if it's he never wants to shower, I try to get him to shower and he'll never shower. Well, that's too big. That's too big of a place to start. So let's start with just yesterday when he wouldn't shower, and see if we can come up with a plan based on what happened yesterday. And then based on that plan, you can apply that next time he refuses to shower and see if that seems to be helpful. Or maybe there's new sets of activators and consequences that come up that we could add into the plan. But you just have to start somewhere. It can't be too big. So the get active problem solving is sort of what I've been talking about as we go along here. You want to think about what's a realistic alternative to the problem behavior. The behavior is he won't shower. The target behavior, what we want, is we want him to shower. It may not be realistic to get him to shower every day anymore. You may need to say, well, if I could get him to shower twice a week, that would be great. So you're bringing in some realistic expectations here as part of your plan as well. Then you're going to think about activators. What's going on, that could be changed? How do you approach him about showering? What are the words that you use? What's the tone of voice? Where is he? Is he always engaged in like his favorite sports game when you say, oh, it's time to turn off the TV, go shower? Are there different times, or is it always a certain time of day that you're trying to do it? Just think. If we paint as big of a picture as we can about what's happening before the refusing to shower occurs, then we can think about, oh, I wonder if we could change 1 or 2 of these things and see what happened. And similarly, the consequences. When he refuses to shower, what do I say? How do I say it? What are the words I use? What's my tone of voice? Do I push it? Do I back away? Do I, what things have I tried? What could I maybe try to do differently? It is not helpful to say, or ask a caregiver, or ask yourself, what triggers the problem behavior? Okay, caregivers like this word triggers, and clinicians do too, because it kind of has a catchy feel to it. You have this idea that you're going to get the magic bullet. But, if you say, well, what triggered the behavior, the caregiver will always say, I don't know. If I knew that, of course, I would eliminate it. So you want to think about what is the situation, what's the context in which the problem happened, and think of all of the pieces you can brainstorm possibly that are in that context. And then similarly, the consequence, what you don't want to say to the caregiver or yourself is, okay, when he refused to shower, what was the consequence? Because if you just say it that way, what likely you're going to get is the caregiver is going to say, it made me really mad. Well, that may be true, but what the consequence we're really interested in is when you were mad, what did you do? What did you say? How did you respond? What's your nonverbal communication? What's your physical actions? What are the steps that you took? Because that's what's going to either increase or decrease the likelihood of the behavior getting worse or getting better. Not how it made me feel when the problem happened, but how did I respond to the person? Does that difference is that clear? And then communication is so important. It's both an activator and a consequence. You want to think about that. Okay, so here's a case example. For those of you who have printed out handouts, this is a different case example than you have in your handouts because I'm David LaFazia for tonight, and he had included a case of mine in this talk, which I want to talk about in 2 weeks when I'm doing my sleep and dementia talk. So I have eliminated the sleep example because I'll talk about that in 2 weeks. And let's just use this one as a different case example. So here we've got an individual, a woman who's wheelchair bound. She's got an old broken hip. She's pretty, doesn't speak much. And now she's in a facility and she's hitting and scratching, striking out at staff members members when they try to help her dress or eat. And she makes a lot of grimacing faces, and one of the aides has told the daughter that she's always angry now. She always looks mad. And her daughter's perplexed because her mom has not been like this. She's been a very kind of nice person, but the doc has told her this is what happens when you get advanced dementia. You become mean and strike and hit out at your staff. So, if we think about the ABCs of this example, you know, we want to define a behavior, look at what happens before, and look at what happens afterwards. And we want to consider all these domains, right? The physical, cognitive, environmental, and historical. And you're at a disadvantage because you've only seen this story for a few seconds here and don't have it on your handout. So if we just sort of look at it before I go ahead a little bit and think about what are some possible physical activators for mom hitting and striking out. Pain would be a possible one that might be causing it. Sensory deficits might be contributing to it. If mom can't see or hear the staff people, if they're not introducing the care in a way that she understands, she may be responding because she's startled or overreacting to it. Certainly she may be more confused because of her dementia getting worse about what's going on. She may not recognize the staff members are providing care. In environment, historical things might be going on. Communication things. We don't know how the staff member is responding. Let's see what, in my example, what I came up with. So in this example, the person with dementia, she's hitting, shoving, pushing during activities of daily living care. This is uncharacteristic of her, according to the daughter. So the staff tells us, well, this happens either in the morning or evening. There's not any particular time of day. It's almost every day. The staff need to get the feeding and the bathing or dressing done. And so even though mom's kind of striking out, they're just sort of, you know, they're just kind of plowing through it. They're making it happen because it's got to get done. So they're insisting. This is a woman, we're told by the daughter, who's been a lifelong teacher. She's accustomed to be treated with respect and kind of being very independent. She's had this hip fracture in the past. There's other residents around, particularly during mealtime when this is happening. So other people are like watching while the staff are like, you know, force feeding mom. When mom starts hitting and shoving, the staff, they try to logically reason with her, you know. They get frustrated because now feeding or dressing is becoming a two-person job, and, you know, they only have so much time, and they don't know why she's gotten so irritable, and sometimes they just give up and let her, you know, stay in her jammies, or they don't make her eat. But lots of times they, you know, they force through the dressing or the feeding care, and their frustration is evident. So if you think about places where we could possibly intervene here, we might check with the physician to find out if any of mom's agitation during, like, dressing is being caused by pain. You know, she might have re-injured something, or it may be, you know, if she had a different kind of clothing that was easier to get on and off, it would be more comfortable for her now. Maybe she's in the wheelchair so much she's started to sort of stiffen up, and so she's got like more joint pain. Maybe if this isn't related to the hip pain at all, maybe it's related to arthritis or some other, you know, medical condition. Maybe mom would do better if, as opposed to staff just getting fed up because she's not eating or dressing on her own, and so they start doing it for her, if they could take the time to step her through a participation in the activities. They might have to cue her each step of the way, which does take longer, but it might engender less agitation and upset because mom would feel more respected and autonomous and you know, involved. It may be that things like personal care should be done in private. You know, that if you're going to have to feed mom, maybe take her back to her room and do it so that the rest of the, you know, unit isn't like gawking at her while the staff is making her eat. Maybe a different time of day. If you're going to try to get her to eat or dress, maybe give her coffee and toast in the morning before you know, as opposed to just getting her dressed as soon as she, you know, you go in the room and say, okay, time to get her dressed, like getting her clothes. Maybe she needs some time to kind of get warmed up to the morning to get involved. Watching the verbal and nonverbal communication during care. In in my work, I've often told caregivers, if you remember nothing I say to you, remember this: don't argue. Logical reasoning, rational discussion, arguing to convince someone, that's what we do with people. That's how we all communicate, but it doesn't work with people with dementia, and it becomes increasingly ineffective as cognitive impairment progresses. So you need to give it up. You need to, there's someone I heard on NPR sometime in the last year. It was a couple, and both of them are stand-up comics, and they do improv comedy. And now mom, the wife's mother, had Alzheimer's disease and was quite demented. And they had discovered that their skills with improv were very useful when working with this person with dementia, mom, because she would say these most outrageous things, and rather than get into an argument about whether it was true or false, or whether it was right or wrong, or whether she shouldn't have said that, it was appropriate or not, they would just sort of start riffing off of what she said, the same thing they would do. And I remember the piece, it was lovely. The husband, so the son-in-law, was better at this than daughter was. It was harder for daughter to kind of get that space and make that kind of move. But I think it was a lovely example. And in fact, these people, you can probably find them, Google them somewhere, because I know they have a web page that I found at the time. That it's a lovely example of how arguing is very ineffective, but kind of going with the flow can be very effective communication-wise. So ABCs, you want to set realistic goals. You want to pick problems that can be changed. He's in denial that he has memory loss. That isn't a problem that can be changed. Not showering often enough is a problem that can be changed. You want to pick problems that occur frequently. If there's been one time that your husband has gotten very frightened and struck out at you, and that was a year and a half ago, and it's never happened since. That's a serious, important behavior, not to minimize it, but it's not a good one to do ABC problem solving with, because it doesn't happen often enough that you can look at activators and consequences and come up with a plan. You want to be consistent with your ABCs. If you come up with a plan, try it for a week and see what happens. Sometimes plans take a little while to show changes. Now, if you try something and it's disaster, there's a catastrophe that follows, well, then you don't have to keep trying that for a week, obviously. But, consistency is going to be important. If you've got 3 shifts worth of people that are in there, if there's the wife and there's the daytime nurse's aide and there's the nighttime nurse's aide, then it would be good if they're all on board with the same plan, because otherwise it's going to be less likely to work. Look for positive approaches. Try. Triggers can be small. Give it time. ABCs, they're simple, but they're tricky. They're tricky because, for one thing, when you're tired, it can be difficult to be creative in this brainstorming, particularly if you're all by yourself and you're trying to come up with ideas on your own when you've tried to come up with every idea that's possibly imaginable already. Behaviors are influenced by more than one thing at a time. So, like I said, there often is not a magic trigger or a magic consequence that will work. But as I said earlier, sometimes if you change even one of the multiple things, you will make a difference in the behavior, because everything's like a spider web. It's all interrelated. The message being communicated is more important than the actual behavior. Observation is critical and challenging, and the caregiver is always right. I've many times gone into the homes and we brainstormed a list of ideas to try, and I say, okay, which one are you going to put? What are you going to change this next week? And the caregiver says, I'm going to change that. And I think to myself, that'll never work. That's like the worst idea on the list here. But I don't say that, thank goodness, because when I come back the next week, it worked just fine. Caregivers know their situation, and again, there isn't one right solution. Sometimes making any change in a situation that has become kind of entrenched in a problematic way can make a big difference, particularly if it's a change that has to do with communication. So this is a summary of the ABCs. Describe the behavior, look for activators, antecedents, and consequences. Develop a plan, give it a try. Evaluate success. If it works, great, keep doing it. If it doesn't work, brainstorm some new ideas or pick some other things off your other list of ideas and go on to the next problem. So the last thing, and I'm going to start running out of time here, so I've got to move along, is pleasant events. And I'm going to move along, but not because this is unimportant. This is really important. So let's just make the point that people with dementia are at high risk to become depressed. You know, and doesn't that make sense? People with dementia are losing a lot. Friends aren't coming over like they used to. They're not able to do many of the activities they used to engage in. They may have, you know, feelings of worthlessness because people are taking things over for them. So you may see many of these behaviors, observable signs of depression in a person with dementia. And depression is a downward spiral, right? Once a person gets depressed, then they're less likely to want to go out and do things. And when they're less likely to go out and do things that are enjoyable, then they're more likely to get depressed, and it kind of really spins downward. So pleasant events can be very important in this situation. We know, social learning theory tells us, in fact, that the ABCs have in part come from, that decreased pleasant events contribute to depression. A person who doesn't have anything in their life that's pleasant is more likely to be depressed than a person who has a lot of things in their life that is pleasant. And I think all of us can think of examples that would prove the truth of that. And caregivers can help they can help identify pleasant events that are appropriate and meaningful for a person and help implement those. So what we want to do is we want to keep adding on the pleasant events. We want more pleasant events, and that's going to lift mood. But you need to find pleasant events that the person will do. So you need to think about, what does the person enjoy in the past? You know, a person may not be able to play bridge anymore, but they still might enjoy a good game of Go Fish if you don't care if they're following the rules. You know, they may not be able to build furniture, but they may still enjoy having sandpaper and an old desktop that they can sand down, you know, in the shop. So are there things that they enjoyed in the past that could be modified to accommodate their current level of abilities? And who's going to be available to help with that? You know, sometimes caregivers say, well, I have to cook the meals and I have to get him dressed and to bed, and now I have to be an activity director too. You know, it can seem overwhelming too. But hopefully you'll see that's not such a problem in a minute here. This is a pleasant event schedule developed by Linda Terry and Rebecca Logston a number of years ago here. And the PES has like 20 items on it. There's a longer version as well.
There's actually a copy going out to the site coordinators from Rebecca's talk.
There's a copy going out to the site coordinators from Rebecca's talk. So what I like about this list, for me personally, is not the activities that are on it. The activities are fine. But, you know, there are entire books you can buy out there with nothing but lists of pleasant activities, the things you can do with it. There are Montessori books out there about activities you can do with people with dementia. What I really like about this schedule is it highlights the relationship between frequency and enjoyability. So if you've got someone who goes shopping every day, he goes with his wife because she can't leave him alone, and she has to go shopping every day to go, you know, get the food. And he does not enjoy going shopping at all, then maybe there's something to learn from that. You know, or if there's something he loves very much, he loves listening to music, but it's been months since wife has put on any of the favorite music that he enjoys. If there's a big discrepancy here, things people enjoy that they're never doing, is there a way we could start having them do it more? If there are things a person's doing all the time, watching TV, shopping. I joke about that. Linda's a big shopper. I am not a big shopper. You know, when I get demented, my husband takes me shopping. It's going to be a source of agitation rather than a pleasant event for me. So I think that's what's particularly valuable about this schedule. It's not the list of ideas, but the concept. Look at frequency and enjoyability and try to get a better match that those are doing enjoyable things more often and unenjoyable things less often. Activities have to be enjoyable to the person with dementia, because there's a bingo program at your adult day center, it doesn't mean that everybody's going to like to play bingo. So Robert Davis, writing a book about his own experience with Alzheimer's disease, says, I have the right to refuse any activity I don't find entertaining. These are just some more ideas about pleasant events, and again, there are so many things out there that can be done. But what's important about pleasant events is to remember a pleasant event is anything that adds pleasure to a person's day. And it doesn't have to be just fun. It can be anything that gives a person a sense of self-worth. You know, chores around the house for many people with dementia are incredibly pleasant. A caregiver told me once, my wife, she washes the windows like 5 times a day. It drives me crazy. And I said, well, it's not hurting the glass any. You know, it gives her a sense of being useful. She's doing something she enjoys, and it's helpful. You know, and so if it's something that adds self-esteem or meaning or value to the person's life as well, or is enjoyable, and it doesn't have to be big. Every interaction has the potential to be a pleasant event. Every time you greet that person, you can greet them with a smiling face or a pat on the shoulder or, you know, a pleasant tone of voice or a joke. Pleasant events to work have to be available, accessible, and frequent. It can't be something that's going to be burdensome for the caregiver. You know, if caregivers think of pleasant events as being some big deal that you've got to like get them bundled up and, you know, go to the museum or something, it's going to be, it has to be something that can be easily accessible on a regular, frequent basis. And the more ideas you have, the better. So in summary here, as we're getting close to the end, advantages of behavioral treatment is, you know, there's no side effects to behavioral treatments. There's no medication dangers here. Behavioral treatments look at kind of the context in which behaviors occur. They look at the situations in which problems are more likely to arise and address kind of the interpersonal and environmental causes of these. They can be incredibly empowering. A caregiver who has a successful experience of coming up with an idea that makes a big difference in something that he or she has been grappling with has this sense, this aha, you know, I can do something. You know, I may not be able to, I may not have a medication that's going to stop my husband's brain disease from progressing, but I can make his life and my life better. I have some tools to do that. Incredibly empowering. And those tools, like I said, they work anywhere along the spectrum. In fact, you know, they work probably, if we would use our ABCs with, you know, our spouses and our kids and our coworkers, they would probably work there too. You know, there's nothing that's special to dementia here for these things. Our approach, again, the family caregivers are the experts. We're just consultants. It's often necessary to get other family members involved in addition to other healthcare providers. If you have kids in the family who are in disagreement about, you know, how best to deal with a situation or how mom or dad are functioning, and they're bickering about it, it's going to make it very difficult for the spouse, you know, and the family to deal with the situation. So you need to sometimes get multiple people involved. This is a slide that Linda Terry has used for years that captures the idea that mood and behavior problems in dementia are an excess disability. They're like a ball and chain. So a person with dementia, he's like the person with a broken leg. They've got a brain disease. He's got a broken leg. It limits what he can do in his daily life. But if you could cut that ball and chain off, even with the broken leg, even with the brain disease, he or she could get around a lot better. If we can get rid of these mood and behavioral symptoms that are so exhausting and stress-provoking for both the person with dementia and the family caregiver, then the person with dementia is more likely to be able to function at the highest level that they're capable of functioning, given where they are in their disease. And that's what we want. We want to enhance their quality of life for wherever they are. So I think this is the last slide, and it's just this is us, our current team, and I did it. I finished on time.
So hopefully they'll turn on the chat in a minute. Are there any questions in the room while we wait for that?
I was thinking, you know, with family caregivers, you know, you have your professional caregivers, and the family caregivers could be trained to do things more like, for instance, you know, it's such a dynamic thing, the progression of dementia. I was thinking how important it would be for even family caregivers to record, to do, you know, a form of charting, and that they can look back on, because a lot of times they're just kind of going from one thing to another, and I don't know what your thought is.
I think that's great. So the question, the comment observation is it seems like it would be very useful for family members to chart, almost like people, staff caregivers in a facility, or, you know, or a home aide will chart. And I think that point is very well taken for this ABC approach that I'm talking about. keeping a log of some sort is incredibly valuable, because if you just try to remember what happened yesterday before he refused to shower, you often won't get it right. Whereas if you sit down immediately after the event and write down notes, this was what was going on and this is what happened afterwards, and then you do that, you know, over the next week or two, and you see every time it showers there's some commonalities here, then it gives you a lot of information to figure out a good problem-solving plan that's likely to be generalizable. It's even above and beyond what staff are accustomed to doing in charting, because staff will just chart, you know, meds given, got upset, refused to shower, and we have to work just as hard, maybe sometimes harder, with paid staff and facilities, because they are in such a routine of what charting means to them that the idea of going this extra step and keeping track of things like activators and consequences can seem burdensome until they get into the habit and realize how potent it is for bringing about change. But that's a great observation.
So we have a question, is it possible to get the references for the slide with the Seattle protocol umbrella? Perhaps Barb could forward them to the site coordinators.
Oh, yes. I can send that to you tomorrow.
Okay.
And what those will be, those references were dates of grants that were awarded by principal investigators in our research shop. So what I can do, I won't send you the grants per se, I can send you the titles of the grants and then a couple of illustrative articles that go with each of those. So, for example, the randomized trials.
They are going to get the papers, the two papers, I guess, on the Pleasant Events scale, I think. That's part of what Rebecca sent.
Okay. Yeah, but, and I can just, I don't know if, I can send you the list, Barbara, or I can send you the actual papers. You can talk to me later. Give me the background, let me know what you want. Okay.
It's really something to think about. Are there, therefore, enough caregivers in these facilities?
You know, that's a hard question to answer. I don't think the number of caregivers in many facilities is the problem. I think facilities are quite a mixed bag in how well trained staff are for dealing with mood and behavior changes related to dementia. Some are quite well trained and are excellent, and some, even people, you know, with higher level nursing and medical degrees, are shockingly ignorant about some of these factors. For example, how sensory deficits. You know, I've been called into an emergency room where a woman with dementia was quite agitated and combative, and it turned out she'd lost her hearing aids weren't in. And once she got her hearing aids in, she could hear what was going on. She wasn't so frightened, and she was fine. So, you know, the fact that in some medical settings there is a tendency to just attribute all behaviors to natural progression of dementia, not to anything that's modifiable in the interpersonal or psychosocial environment, is a problem.
So Anchorage says, one of my biggest struggles is getting adequate and accurate communication from staff to staff on day-to-day behavioral issues. Just so stuck in getting the day's job done.
Yeah, that is really true. I'm consulting with the VA now on a national program that they're rolling out this approach in their community living centers with dementia residents. And something that they've really grappled with over the various sites is how best do you document these kinds of things? How do you build this kind of communication from shift to shift, what plans are, and brainstorming activators and consequences and coming up with plans without it adding a whole lot of extra work and paperwork into already very busy people's days, and like you say, just communicating from shift to shift and even within shift from professional to professional. It's very, very challenging, and every site has their own challenges because every site does things differently, even within a system you'd think would be more homogeneous like the VA. So I'm sympathetic with that.
So, question, one-on-one caregivers sometimes does not seem enough. It's training and approach which makes